Yeah, hi everybody. I'd like to welcome you all to this information session on the recommended changes to the UW benefits plan, and thank you for taking your time to attend the session. My name is David Saunders. I'm a member of the faculty of the Department of Statistics and Actuarial Science, a FAO-nominated member of the Pension and Benefits Committee, and a member of the Holistic Benefits Working Group. The P&B committee has majority representation of employees from across the campus community, and these recommendations have the support of the P&B committee. Today's presentation comes after a long exercise to review the benefits plan. As part of the presentation to be given today by our consultants at Aon, there will be a description of the process and the proposed changes. P&B has approved the recommendations that will be presented today, but final approval will only come from the Board of Governors. We anticipate taking the recommendations to the board in February, only after these information sessions and hearing feedback from the community. And with that, I will turn things over to Aon.
Thanks, David. So again, a couple of housekeeping items before we get through. First again, if you're dialed in, please put yourselves on mute and feel free to turn your cameras off during this time. There'll be about a half-hour presentation and try to keep at least half an hour at the end for Q&A. Please be advised the session is being recorded. Please don't let that stop you from asking your questions. I mean, ultimately, the session is for you, so you understand what's changing and how it affects you moving forward. So we encourage your questions, which is why we'll spend half of today's time focusing on that Q&A. Feel free to use the chat feature. We'll be taking questions. Well, if you have a question, please throw it in the chat. And we can address them, the second half of the presentation during that Q&A time. You can write in the chat at any time. Mike will be monitoring it, but we probably won't get to answering those questions until the end. Alternatively, when it does get to the Q&A, you can raise your hand, as you can see through the button through Teams. And if you're asked your question rather than typing it into the chat, you can take yourself off camera if you'd be so bold, so we could actually see face to face. Because right now, working in this kind of virtual environment, trying to look at the head count here, we probably have about 25 people dialing in from 25 different places. So it's sometimes nice to connect face to face. So that being said, Linda, if you want to switch it over to the main presentation, a quick introduction on myself. My name is Scott Palmer. I'm an Associate Vice President in the Health Solutions practice at Aon, and I've been involved in working with the Holistic Benefits Review Working Group throughout this process, trying to determine, what changes should be made to this benefit plan moving forward. And ultimately, that's what we're here to discuss today. So thanks, Linda. I can see your screen now. Right now, the way you're showing it shows the main slide as well as the next slide coming forward. So I'm not sure if there's a way to change the view to just see the one slide at a time.
It might be, if you just get back to the regular dialogue and if you hit F5, I'm not sure if you're on a Windows machine there, Linda, but that should just give you the full screen mode. If you can escape out and then.
Linda, you had it right. Go to display settings, if you wouldn't mind, and then swap the presenter view and the slideshow.
Yeah.
Wonderful.
Thank you.
All right. Wouldn't be a virtual environment without some kind of quick technical hiccup, but I think we're already on track more so than the first session today. So as for the agenda for this hour, Linda, if you want to flip the slide, I believe we've got 15 minutes at the start, roughly, as this welcome, giving a little background on the Pension and Benefits Committee, as well as kind of the purpose of this session, trying to focus as much time on the core presentation itself, which is the background of this entire benefits review process, but more importantly, what is changing and how it affects you moving forward. And again, trying to save about half an hour at the end for some Q&A. So next slide. So the Pension and Benefits Committee membership, as you can see on the screen, a variety of members from the university and various stakeholder groups, and the resources at the bottom, combination of HR, finance, as well as a few of us from Aon. Myself, Scott Palmer, again, being the, I guess, the health expert working with the university, and happy to be here today presenting to you. Next slide. So, Pension and Benefits Committee, hopefully everyone on the call has heard of it. It's a committee from the Board of Governors, ultimately responsible for the administration of the pension and benefits plans, really focused on the stewardship of these programs, making sure they remain competitive, as well as keeping in mind the financial context, both for university and how much the plans affect the university's budget, but again, also focusing on employees and how much they're contributing to the programs. And so today we're really focused not on pension, but on the benefits program, as that's kind of the purpose of this review, as well as what will be changing moving forward, all focused on the benefit plan, both active and retiree benefits programs. As additional background, the P&B committee has a few guiding principles in terms of how it views these programs and decides to make changes moving forward. One of the main philosophical points that it wants to keep moving forward is there's one plan as much as possible for all groups, not trying to differentiate programs between the individual staff, faculty, QP, active as retirees, trying to keep one plan for everybody as much as possible. We're trying to provide benefits coverage for both the employee and employees' dependents, making sure that coverage is included in the benefits program for catastrophic events. That element of insurance is very important. Trying to maintain the same level of benefits, not wanting to reduce coverage, but looking at ways to keep it modern, meeting the needs of both the employees and the financial constraints from the university. And again, financial, we touched on before, keeping in mind the university's budget, but also how much employees are contributing to the program as well. Internal Policy 23 requires the same health plan for active employees as well as retirees. And so any changes made to the active health plan follow through and affect retirees as well. So why are we here today? Well, there's been a process for the last few years from a holistic benefits review, and an outcome of that is recommending changes to the benefits program moving forward. So the P&B committee has taken the final set of plan design recommendations. They've approved it. Next step would be going to the Board of Governors next month to get final approval. Ultimately, all these changes will be effective May 1st this year. And so the purpose of today's session is to explain the process of how we got where we are, and to answer your questions as well. So sometimes I know it's can be a little intimidating to ask questions either through the chat or through video at the end when it's a big group setting, but please, these sessions are for you. So happy to answer any and all questions to the best of my abilities. Next slide, Linda. So give you a quick overview, a little flavor of what's changing here. So variety of coverage enhancements are being put through for May 1st. Increased mental health coverage, both the annual maximum as well as the type of practitioners that can be claimed under that maximum. Some additions to the benefits plan coverage, including continuous glucose monitors, as well as in vitro fertilization. Trying to make the plan a little bit easier to use for members by removing the doctor's note requirement for certain paramedical practitioners, like massage therapy, speech therapist, psychologist. We're adding athletic therapist as an eligible practitioner to the program under the physiotherapist banner, increasing out-of-country coverage to $5 million lifetime, which will be very useful, I guess, once we're back in the ability to travel again and the lockdown's lifted. And then finally, increasing the dependent child age from, I believe it's 23 today, to age 25 for full-time students. And within that financial context, how are we going to pay for these enhancements? Well, we had to find cost savings through the program. And you'll see on the right-hand side of the screen there, the changes being made that generate cost savings. And they all stem around the management of prescription drugs. So the changes being made include making it mandatory generic substitution. So where a generic drug exists, only reimbursing up to that amount. And then implementing 2 drug management programs offered by Canada Life, Health Case Management, as well as their SMART drug management program, which I'll go into in a lot more detail in a slide or two. So maybe first a little background in terms of how we got where we are today. So back in 2018, the P&B committee embarked on this holistic benefits review. A subcommittee was formed, including various representatives from the various stakeholder groups, QP staff, faculty, and retirees, as well as some representatives from the universities, affiliated and federated colleges. And the goal of this review was, 1, to make sure that the plan remained competitive relative to the industry and kind of universities' competitors, and then to address any gaps in coverage identified. And so ultimately, going into this this project, the goal is for the new plan design to be cost neutral. So any kind of gaps that we'd want to close, benefit enhancements to put through, we'd have to find ways of generating those savings within the plan to keep that cost neutral goal. And so if we couldn't find a way of doing that, ultimately we could look to implementing employee contributions to the program as ways to fund the enhancements. But trying to review all those options and keep everything cost neutral from a university's perspective. There's a little bit more information posted at that link at the bottom of the slide regarding the process from the Holistic Benefits Working Group. And I'll just pause a second in case you want to jot down that link. So the next slide, Linda. The first step in the process was a competitiveness review. And so in early 2018, we benchmarked the university's benefits plans against 21 other employer plans, a mix of university and non-university. Some of the universities included in that group included the local competitors, so Wilfrid Laurier, Western, U of T, University of Guelph, as well as some private organizations as well, just to see how the university program compared. Overall, the benefits plan is quite competitive relative to the industry. Some of the strengths of the program included life insurance, pretty rich coverage relative to the market, as well as short and long-term disability. Dental coverage fared quite well, especially when you take a look at the enhancements put through for January 1st, 2019. And then as an item that stood out as a strength of the program was that there's currently no required contributions for full-time members towards medical and dental coverage. So even though we may have identified a few of the gaps at the bottom, the plan is 100% funded by the university. Part-time members would have a contribution, of course, pro rata based on the number of hours they're working. But through this process, we did identify some coverage gaps that we were hoping to address as part of this process. The biggest that we were able to identify is vision care. So lack of coverage right now through the university program for things like eye exams, glasses, contact lenses, laser eye surgery. The plan also didn't have some of the more modern items, things like continuous glucose monitors or in vitro fertilization, which is becoming more common within the industry. As well as when we looked at the retiree coverage and specifically against the other university comparators, it stood out that the University of Waterloo program did not offer dental coverage for retirees. That being said, the retiree program as a whole fared fairly well competitively against the other university programs, mostly because the other university programs, other universities required retiree contributions to coverage for both medical and dental, whereas University of Waterloo currently only offers health, but it is a 100% university funded program. And then a few items that there is coverage, but maybe it was a little bit lower than what we were seeing from the comparators. Two of those being chiropractic care, as well as out of country. Perhaps could use a little bit of a bump if we were to, of course, go through this process and go through the redesign. So with this information in our back pocket, we took the next step in the process, which was an employee survey. As you may remember, back in fall of 2019. I almost said last year, but I guess it is 2021. Back in 2019, there was an employee survey that was released. We ended up getting about 40% participation from the eligible plan members. And really what the survey was focused on was trying to determine the degree of change employees wanted to see, and framing it in that cost neutral context, meaning, what do you want to see added to the program? And then what would you be willing to give up in order to fund those enhancements? And so when we took a look at the results, some of the items that employees really wanted to see added to the program, top of the list was vision, eye exams, glasses, contact lenses, the same as was identified as a gap in that competitiveness review. There was also a little bit of a frustration of requiring these physician referrals for things like paramedical practitioners. Mental health was a concern as well, and employees wanted to see enhanced coverage there. And then from a retiree perspective, identifying that gap as well of retirees currently don't have access to dental coverage. So those are the four main additions employees wanted to see added to the programs moving forward. And then when we looked at the list of what employees were willing to give up or to spend in order to get these enhancements, the two that kind of made the top of the list was better prescription drug management, which included the mandatory use of generic drugs, as well as potentially adding employee contributions to the program. Now, that last bullet was split between the various groups within the university. So some groups, definitely wanted to see more employee contributions, but for some of the groups or members, maybe on the lower end of the income bands, it came through that they did not want to see the employee contribution. So kind of a mix between the groups when we broke down the survey results. And so taking this information, the competitiveness, as well as the employee survey data, the Holistic Benefits Review Working Group reviewed the results and came up with a variety of alternate plan designs, trying to identify as many of the gaps as possible while managing kind of the items that would generate cost savings. A couple of these designs, which were close to final, were brought to the various stakeholder groups for feedback. And the biggest piece of feedback we received in this process was really a concern for members with lower incomes, because if you think about some of the enhancements we were looking to put through, things like vision coverage is quite expensive. And so in order to generate enough cost savings to fund an enhancement like that, you'd have to find a pretty significant takeaway or a pretty significant employee contribution in order to fund that kind of benefit. But the stakeholder groups kind of provided that feedback of, we're really concerned for those members, lower income groups. And so a few of the suggestions that initially came from the Holistic Benefits Review Working Group had to be modified. And then finally, based on that feedback, a final set of design changes was made, brought forth to the Pension and Benefits Committee, which received approval. And that's what we're here to talk about today. The final set of recommendations only impacts the health plan, as we alluded to earlier. There are no changes to life insurance, to disability, or to dental. We're simply focused on the health plan. And so when I say health plan, what do I mean by that? So the health plan provides coverage for plan members as well as their dependents for things like prescription drugs, paramedical practitioners, which are physio, psychologist, massage therapist, covers medical services and supplies, hearing aids, orthotics, orthopedic shoes, items like that. Some coverage for hospital, as well as out-of-country coverage. And again, as a reminder, the plan is currently 100% university paid for full-time members, and cost shared for part-time members on a pro rata basis. So digging into the changes that are being recommended and put forth for May 1st, 2021. First, focusing on drug plan management. So within the health plan, drugs is the largest category, making up roughly about half the claims from the overall program. And so it being the biggest bucket also had the most potential for cost savings. And this was one of the items that came forth through the employee survey that members were willing to have a few tweaks made to that drug program to generate some savings in order to be funded for some of the coverage enhancements. And so the main change generating the savings that we're reinvesting in the program comes from the use of generic drugs. So right now the program encourages generic drugs, but if your doctor writes no substitution on the prescription, the plan reimburses at the brand name level, which tends to be a little bit more expensive for the program. In general, generic drugs today in Canada cost maybe 10% of the brand name cost. And so the more we're able to shift claims towards the generic drugs, the more savings we generate. And that's really that first bullet of what's changing. The generic drug should work for most plan members in the majority of cases, but there are very rare cases where that generic drug doesn't work the same for a plan member, at which point, if that's the case, there is an exception process through Canada Life where, working with your doctor, you'd fill in a brand request form, submit it for approval. And if there is truly a medical reason why a generic can't be tolerated, the plan would still reimburse that brand name drug. A bit more of a hoop to jump through there rather than just the word on the prescription. It has to kind of go through this exception process. And then 2 additional drug management programs, Health Case Management and SMART, which we'll touch on in a couple slides. I think the next slide here, again, just touching on generic substitution, just wanted to define a couple terms to make sure we're all on the same page. So there's basically 3 sets of drugs within the program. A single source brand name drug is a brand name drug that does not have a generic equivalent in the plan, and it's still covered under a patent. And so these drugs, which make up maybe half the drugs coming through the program today, aren't impacted by this design change. These are the only drugs that may work for a given condition. They don't have that generic alternative, and so they're covered today, and they'll be covered after May 1st as well. But it's the next items, the multi-source brand. These are brand name drugs that were single source, but have since lost their patent protection. And then once they lose their patent protection, other generic drug manufacturers can come in, manufacture the same drugs, but generally the ones that they manufacture, while they're the same medicinal components within the drugs, they tend to be about 10% of the cost of the brand. And so that's what we're really trying to shift, is those who are using multi-source brand name drugs today, and shifting them to using the generic drug, which, by all intents and purposes is the same drug, just cheaper and generates those cost savings for the university. The next 2 programs, Health Case Management and SMART, are different ways the plan is being managed moving forward. And for the vast majority of employees within this program, you're not going to notice any changes. But it does affect a few members moving forward, and so you may fall into one of these buckets. So let me explain the programs. So Health Case Management is designed to assist plan members who are on very complex, they have complex chronic conditions, and they're on a very expensive medication to help treat that condition. Examples like rheumatoid arthritis or Crohn's disease. Typically, the drugs that would fall under this program would be fairly high costing thousands, if not $10,000s of dollars every year. So what Canada Life would do is engage Health Forward Inc., one of their partners, to provide this service. And if you're prescribed one of these drugs and being reimbursed under the program, a health case manager would reach out to you, who is a qualified healthcare professional, and they would help you manage your condition as well as the medication that you're on. So they help working with you and working with your physician, making sure that the treatment is effective and appropriate, helping answer your questions, providing support as needed, making sure that the medication is being taken as directed and you're adhering to that, and then monitoring results as well to make sure that those drugs are in fact working for your condition. And so cost savings come out of this program by, I guess, one, making sure that drugs are being taken appropriately, so you're getting the best outcomes from them, but at the same time directing you towards a specialty pharmacy network that would generate some savings for the plan just by moving to cheaper pharmacies. And so through Canada Life's designated network, it does include Shoppers Drug Mart as well as Loblaws And so finding a pharmacy locally should not be an issue. And again, this program does not apply to the vast majority of medications, but only those high-cost drugs used to treat these complex conditions. But not only is it managing costs and generating the cost savings, but also just by working with a health case manager should actually end up creating better health outcomes for you as you're managing a complex condition. The second program being implemented is called SMART, which is an acronym standing for Sustainable, Managed, and Reasonable Treatment. And this comes down to how drugs are being added to the program moving forward. So in today's world, a drug gets submitted to approval for Health Canada. If Health Canada approves it, automatically that gets added to the program, and the program will reimburse and pay for any claim for any drug that's approved by Health Canada. And so moving forward, this program helps to protect, from a cost perspective, if more expensive drugs are being added to the program that aren't more effective than existing medications. And so how the process works is when a new drug or maybe a new indication for an existing drug gets approved by Health Canada, Canada Life, through independent consultants and TELUS experts, review the drugs themselves for clinical effectiveness, safety, cost effectiveness, really making sure that this drug makes sense to be added to the plan moving forward. If it's the only drug that treats a condition, I imagine it'll fly through this process and be added. But really it comes down to, if a drug's being added that's more expensive and less effective than an existing treatment, well, why would we add that drug to the program? Let's use the cheaper and more effective drug. And so really they go through the process, and the outcome of their review, which might take 6 to 9 months, is either the drug gets added to the plan, no problem, no constraints, similar to most of the drugs in the plan today. Could be excluded from coverage, it isn't cost or clinically effective. Or in the middle of, maybe this medication makes sense for some members, but, either through a prior approval process, working with a physician, or, directing, maybe you want to try the cheaper drug first, and if it doesn't work for you, okay, move on to this more expensive drug. This only impacts future drugs being added to the program. So any medications you're currently taking are not affected by this. They will continue to be covered by the plan, outside of maybe encouraging you to move to that generic drug through the change made 3 slides earlier. So through more effective prescription drug plan management, cost savings will be generated. And now through those cost savings, dollar for dollar being reinvested in some kind of enhancements moving forward. So I touched on these earlier, but a bit more detail in terms of what's being enhanced. Psychologist coverage is being increased by $200 a year, which brings it up to $943 a year. And then when I say psychologist, right now what's included in the program is a psychologist or a qualified social worker with a master's designation. Those practitioners will continue to be included under this maximum, but we're expanding it to include registered social workers as well as psychotherapists. The idea here being, 1, just more coverage every year, but 2, perhaps if you can't visit or can't get access to a psychologist or a social worker with a master's designation, you can access another qualified mental health practitioner and use the benefits. Under the physiotherapist coverage, no increase to the maximum, but we are expanding the definition of what qualifies as a practitioner under that heading to include an athletic therapist. I touched on before that we're removing doctor's note requirements for certain paramedical practitioners, and they include massage therapist, dietitian, psychologist, and speech therapist. Then the other enhancements that are being put forth, I touched on before. I'm not sure how many of these need additional detail. The first being children who are eligible for coverage today, their coverage up to the age of 21 or 23 if they're a full-time student. Moving forward, they'll continue to be cut off at 21 if they're not in school full-time, but that maximum age for full-time students is being extended to age 25. Out-of-country coverage is being increased from 1 million to 5 million lifetime. And this came out of the competitiveness review, where benchmarking against other plans in the industry found that $1 million lifetime was lower than what's commonly being offered under other plans. The other 2 items, again, identified through the competitiveness review, and did come up a little bit through the employee survey as well of items members wanted to see added, was the addition of continuous glucose monitors to help members manage their diabetes, as well as adding coverage for in vitro fertilization to help those developing families. Next slide, Linda. So no changes to life insurance, no changes to disability or dental coverage. Again, just focused on the health plan. And you may have gotten to this point of the presentation and wondering, what about vision? And that was truly the biggest challenge as part of this process. Vision coverage, as well as adding chiropractic coverage or enhancing that coverage, is rather expensive. Vision coverage, as an example, would cost over $1 million a year to be added to the program. And so the working group investigated various ways of trying to add vision coverage to the program under that cost-neutral banner. Vision came up through the employee survey. We heard it loud and clear, as well as the competitiveness review, but really trying to find a palatable option of adding it and balancing it out with something that generated cost savings under the program. Just couldn't find a palatable option to protect members given the cost constraints. So we looked at employee contributions and increasing out-of-pocket limits or decreasing the co-insurance required within the program. But ultimately, through meeting with the stakeholder groups, none of those items ended up being palatable. And so unfortunately, we're here putting through design changes and weren't able to address vision as part of the process. The other item that wasn't addressed was the addition of dental coverage for retirees. Again, trying to find a cost-neutral basis for it to be added. And really, it's rather expensive to add, and trying to find ways of balancing it out. Just couldn't find a way of putting it through these sets of changes. And so, I guess, additional next steps, the changes I walked through on the prior slides, again, going to the Board of Governors in February for final approval, at which point they will take effect May 1st, 2021. There's a couple other items that the working group wanted to address and couldn't find a way through this set of this process, and so has recommended, further follow-up from the P&B committee. Things like expanding eligibility to provide access to benefits on a premium-paying basis for temporary employees for the entire, full suite of benefits coverage, as well as members who don't meet the 10 years of service required eligibility rule in order to get retiree coverage, looking at whether we can find a way of extending coverage to those members if they were to pick up some or all of the cost. A possible next step might also be to review the insurance partner arrangements. So is Canada Life still the right provider for the university moving forward? Maybe taking a look at that in the short term. The P&B committee may also be investigating opportunities or partnerships to add dental coverage for retirees outside of the current benefits program. Again, one of those items that came up through the employee survey, as well as through the competitiveness review that we weren't able to address at this time. And then finally, trying to find a way to address changes in the market and employee concerns a little bit more timely. If you remember back to the background slides, it took a few years to get through this process where we are today. And so trying to find a way of reacting a little quicker to things that come up. But ultimately, that's where we are today. So a few changes to the prescription drug management program that, for the most part, I don't think will negatively affect any plan member. Just a few more cost constraints there to make sure the dollars are being spent wisely. But then taking all those savings, reinvesting it back into the program through the enhancements listed a few slides prior. And ultimately finding that goal of trying to make as many members happy as possible through these design changes, with balancing that cost neutral requirement, and not introducing employee contributions or increasing out-of-pocket limits or something that would negatively impact employees financially. So I think you may have heard me talking long enough. That was roughly the half hour that I promised. That saves us about 25 minutes or so for some Q&A. And so if you feel so bold to ask the question by raising your hand, Mike will moderate that. Alternatively, I imagine there's something in the chat today, so maybe Mike, I'll pass it over to you.
Thank you very much, Scott. Very much appreciated for that excellent presentation. Again, second time today. We have a question in the chat. Nancy Schnarr, maybe I'll just read it off since she took the time to write it in. About the SMART program, is there an opportunity to appeal if a drug has been excluded if someone's medical condition responds more favorably to it?
There's not a formal appeal process that I'm aware of through Canada Life, although let me take that away and address it. We're going to be putting together some Q&A answers that I wasn't able to address today. I don't believe there is, but let me take that away and make sure that's addressed through that follow-up Q&A.
And just for context, for those attending today, we did have a few questions that managed to stump the group, so we are going to be able to update the website and hopefully be able to get in fairly short order some of these answers. Also seeing from the chat a bit of dialogue. I'm not sure if they actually, if it amounts to questions, particularly about this particular presentation, so maybe we'll just leave them on the chat. We had one, perhaps if anybody attending wants to put their hand up or write their question into the chat, we'd be more than happy. So Scott, I'm content to read these to you, but do you happen to have the chat open? I mean, if it cuts out. The question came from Neil Stoughton. How are you going to get those cost savings for drugs?
Yeah, so right now, with the doctor putting no substitutions on the prescription, the plan currently reimburses drugs at that brand name level. But moving forward, Canada Life won't be adjudicating drugs in that manner. The pharmacy won't be following that requirement. So no substitutions then will no longer carry any weight on the actual prescription. So once it's brought to the pharmacy and they fill it, the plan will only reimburse up to the generic cost level if you still intend to take that brand name drug. Otherwise, you'd be able to get kind of the regular plan reimbursement for the generic level. The only way to get that multi-source brand name drug continue to be covered by the program would be to fill in that formal exception process form and submit it to Canada Life for approval. And that's basically saying it's not just your doctor writing a couple words on the prescription, but actually identifying and signing a form indicating there is a medical necessity where the generic drug does not work.
And a follow-up from Neil says, so you're going to ignore the doctor recommendation. And I think sort of jump in, but I do think there was the tiered level that you were talking about at the beginning. Maybe we can go over that again.
Well, sure. It's not ignoring the doctor recommendation. I can see how it would seem that way. Really, there is the exception process to listen to the doctor if there is the medical necessity. I think today, when we took a look at some of the high-level stats of drugs coming through, seemed to indicate that was, no substitutions was being written on the prescription, maybe more than it needed to be, just based on our own benchmarking stats and how plans could be managed moving forward. Doctors sometimes write that without testing out that generic drug first, and so the university doesn't want to be in the position of telling doctors what to prescribe. Neither does Canada Life. All this recommendation and all the drug management programs are really saying, where it makes sense, where it's supported by your physician, let's try the generic drug, the cheaper drug first, and you should get the same health outcomes. But that's why the exception process exists, that if there is a true medical necessity, of course, we'd want to continue to cover the drug that works.
Moving on to another question from Nancy Schnarr. For Chiro, there is a limit for it similar to massage, physio, etc., but they only pay 80% of $12 after the out-of-pocket cap. Why not pay 80% of an appointment cost until the benefit is exhausted? Was that one of the things explored to enhance Chiro coverage?
It was, yeah. So when we did the benchmarking review, both competitively and through some of the employee survey feedback, only reimbursing up to $12 a visit is relatively low in the market. But on that vision slide I covered near the end of the presentation, removing that per visit maximum and covering it like any other practitioner increases costs pretty significantly, which would need to be balanced out with a fairly significant cost reduction in some other area. And we couldn't find a palatable option of removing that per visit maximum for Chiro.
Thank you. Another question here in the chat, Nomer Naeem, are the independent investigators for the SMART program actually independent? And I'm reading this right off the chat. Based on my Hollywood knowledge, it feels like this is a way for insurance company to disallow medicines that are just expensive.
So from a cost savings perspective, you're going to get the most bang for your buck, only focusing on the high cost drugs. But that's not the intent here. I mean, the intent is making sure that the drugs covered under the program, one, are managed by cost, but also providing the necessary health outcomes. So if you have two identical drugs and one's more expensive than the other, you know, I think we can all agree in terms of managing costs, let's take the one that works just the same as the other, but is cheaper. So a couple times, you know, when Health Canada looks to approve drugs, they look simply from a safety perspective and making sure it won't cause any harm. And so what this takes an extra step is saying, well, is it actually better from a clinical effectiveness perspective? And then is it actually, you know, cheaper? And so if you have two drugs that are the same clinical effectiveness, then we'll look at cost. And then if they're different, you know, just because one's more expensive, if it actually provides a better health outcome, it could be covered as normal throughout the program. But that's kind of left up to the independent review board, which is truly independent. They don't have a stake in the game. So I'll leave it at that.
Thank you. So that is the end of questions in the chat. I think I've seen a hand go up in the Dennis Huber, please, if you want to unmute and ask your question.
Scott, it's Dennis. I think it just part of the clarification to the question about independent investigators. It might be useful to explain how our extended health is administered as a administrative services only, and that the insurance company has no financial gain in the arrangement. Sure.
Yeah. So the way the university's program is set up with Canada Life, and is similar to other large employers in Canada, is really using Canada Life as simply a claims administrator. So university is paying all the costs that come through. If there's a lot of claims, university costs go up. If claims are properly or better managed and there's fewer of them, university's costs go down. And Canada Life, you know, for the most part, I say this, you know, tongue in cheek, but they're not holding any of the risk of the program. They simply take the claims that are submitted, adjudicate them as appropriate, as directed by the university, and they're kind of only used from that purpose. And so if high cost claims come through, and you know they meet the criteria of the program, Canada Life will approve it.
Very helpful, thank you. So I'm not seeing any more questions as of this time. So just as I say that.
So so Canada Life, their job is to adjudicate the rules of the program. So, you know, richer plan designs, they'll relax the rules if they want costs more. The employer wants costs more heavily constrained in the rules put in place, then Canada Life adjudicates to that. Their job is to ultimately meet the needs of the university. So whatever the university directs them as the benefit programs to be administered, that's what Canada Life should be doing. And that's how we look at it when we're working with Canada Life to make sure they're doing their job. You know, denying the claims that shouldn't be covered and approving the claims that should be.
So once again, not seeing that many more things in the chat, but I do recall from the earlier session, Sam did take a quick moment to drop a link. Maybe Sam, if you wanted to come onto the meeting and drop a link and just let people know where they can reach out. And then in the meantime, if anybody else has a question, we can pop them into the chat or get a hand up, and that would be fine.
Thank you, Mike. I will pop that link into the chat momentarily.
So it seems like we might be done a little earlier than our expected 7 p.m. end time. If that's the case, then that would be a 14-minute dividend back to all of you. So unless we see another one, I think that we're good for the day. Scott, maybe you can stick around for another minute or two and we can see if anything comes up. But other than that, thank you very much on behalf of Pension Benefits Committee, and have a good night.